Welcome to Hemodynamics. So this one is going to be pretty involved, and I'll try to relate some of this to mechanical ventilation as well. That's where you're going to see a lot of hemodynamic issues, is usually in your cardiac ICU or just your traditional ICUs that are out there. Hemodynamics and mechanical ventilation are synonymous with each other. And I will talk a little bit about cardiovascular hemodynamics as well. When we get to like diagnostic hemodynamics. So when we're looking at this, there's a lot of application, and this is an area that a lot of RTs tend to be a little short. A lot of RTs are very good with mechanical ventilation. They're very good with therapeutics, but when it comes to hemodynamics, they have a tendency to not to understand how that interacts with mechanical ventilation, how that interacts with therapeutics, and how do I know I'm having a therapeutic effect for not only my lungs, but also for the heart, for the physiology of the heart. So hemodynamics is going to play a very important role, and we're going to go through a lot, so be ready. Blood flow through the heart. Hemodynamics is blood flowing through the heart. How does blood flow through the heart, or what are the main structures? And this is important, especially when we get into left to right shunts and causing things like pulmonary edema. And you will see this in some of your patients that have PFOs that are in ARDS, that are in some sort of severe oxygenation crisis. They have a pulmonary edema component because of a left to right shunt. And if all this is not making sense to you, you don't remember what a left to right shunt is, we'll talk about it. But you're going to need to know this, especially when you get into neonates, when you start to look at babies with PDAs, patent ductus arteriosus. Almost every premature baby still has a PDA issue. We know it's there, and that causes a left to right shunt. We have blood backing up into the lungs, which is not good for surfactant, which is not good because it causes pulmonary edema that decreases compliance, which is not good because it makes it harder for oxygen to diffuse into the bloodstream. So there's a lot of bad issues that go on with this. And so the more you understand hemodynamics, the better practitioner you will be ultimately. So I need you to understand the structures. I need you to understand what it means if someone has a pulmonic stenosis or a mitral valve prolapse. What does that mean to you? What would you see? And so we're going to sort of go through some of the different areas here. So I will expect you, right? You are expected. It is free game for me to evaluate you on remembering the different areas of the heart, like the anatomy of the heart. You should know the tricuspid valve, the bicuspid valve. You should know how the blood flows through, which valves close out during systole, which ones are open during systole, which valves are closed during diastole, which ones are open during diastole. You should know that basic function. You should know the flow through the heart. You should know about the aortic arch and what three vessels come off the aortic arch. I expect you to either go back through all those notes from cardiac A&P or to go through your Desjardins cardiac part, right? Go through that stuff again, because that's something that you need to know, especially when you're starting to think about if you want to work in critical care diagnostic medicine. That's going to be important for you, right? That's going to be something you need. Otherwise, you could actually make changes, like per se on mechanical ventilation, that actually cause the patient to get worse, that cause them to need more pressors, that may cause them to go into multi-organ system failure. You could be contributing to that, and that is not something you want associated with you. You want to be the type of practitioner that understands, hey, their end tidal CO2 is going down, their heart rate's been going up, their stroke volume's been narrower, their pulse pressure's been narrower because of their stroke volume, that equals stroke volume. Therefore, we might need to decrease our mean airway pressure, and that might actually improve hemodynamics, which would improve our saturations, which means we could titrate not only vent pressure, but we could titrate how many pressors this patient's on. There's this whole snowball effect, and so I expect you to at least understand the basic anatomy and the blood flow through the heart. So let's start there, and then we'll get into the more serious, deep ends of this issue. All right, so the main issues. All right, so the heart blood flow. Remember, we're going through the vena cavas. And remember, when we're talking about positive pressure ventilation, especially mechanical ventilation, like I said, I'm going to try to put as much application in here as possible for you. When we're talking about mechanical ventilation, we're talking about blood flow returning to the heart via the vena cavas, right? Superior and inferior vena cava. So if we have a lot of thoracic pressure, if we put a lot of positive pressure ventilation on these individuals, we can extend pressure both to the heart and to the vena cava. But let me ask you this: which one's more compressible, a vein like the vena cava or a muscle like the heart? Which one's more likely to see that compressibility first? Right? You'll probably see that compressibility first in your vena cavas, and that's going to be something that's going to stop the amount of blood going through to the right side of the heart, which means you're going to have less blood flow going to your lungs, which means you're going to be able to carry less oxygen, right? It's a perfusion issue. You're actually causing, right? You're causing ventilation without perfusion. You're actually causing a dead space, right? Remember the difference between a shunt and a dead space? Over here, let's do this. Over here, we have perfusion without ventilation. So this is a shunt, right? If there's blood flow and you're not ventilating, that's a shunt. Over here, we'll make it a different color, if I can. We have ventilation, but no perfusion, right? This is a dead space, right? So when we're looking at, we're stopping perfusion or we're restricting perfusion because we're squeezing the thoracic cage so much with positive pressure or mean airway pressure, we're actually causing more of a dead space issue. Well, how would I know if I'm doing this? Well, one of the ways you can tell, and I hope you remember it from critical care class, is end-tidal CO2. If my PaCO2 and my end-tidal CO2 aren't within, let's say, 5 millimeters of mercury of each other, they're not pretty close to each other, then I know I have a dead space issue, right? And one of the big reasons why we can cause dead space issues in positive pressure ventilation is mechanical ventilation, right? We have too much mean airway pressure for what the vena cavas can hold. Now, let me give you the situation. You have a patient with severe ARDS. Right? There's a bunch of edema, there's a bunch of cellular debris, it's pretty much pus, right, for the most part, that's building up into the airways, right, inflammatory mediators, all this bad stuff is building up here, right, so this is ARDS. So all this stuff is building up there, which is making it hard for oxygen to diffuse into the bloodstream, correct? So when we're looking at this, and you're saying, Derek, it's requiring so much pressure to get any good oxygen. Well, of course. Remember, the alveolar air equation tells you how to get oxygen to the bloodstream. Either you increase pressure, you increase FiO2, which is not going to work in this case, or you can get rid of CO2, and this is not usually a hypercarbic issue. And in fact, we love a little bit of permissive hypercarbia here to save lung tissue. So when we're looking at something like ARDS, it creates a lot of pressure, but you're like, Derek, we're not seeing hemodynamic effects. We're not seeing the pulse pressure narrow. We're not seeing the heart rate increase with our increases of PEEP, and we're using 15 centimeters water pressure per PEEP. Because the lung tissue is so stiff here, if you keep going up on those PEEP, you may not see hemodynamic compromise because this tissue is not very stretchy, right? It's like a scar tissue. It's not going to expand very easily, and therefore it's not going to have a lot of compression on the vena cavas. I hope that makes sense to you. So sometimes we can use higher mean airway pressures without causing venous return issues. It depends on the patient's process. This is why you should be a disease expert, right? You should be a master of respiratory and cardiac diseases if you're working in this field. That's going to help you big time. So I can have a patient where we have a good high mean airway pressure and not see hemodynamic effects. But let me ask you this. Their ARDS starts improving, their sepsis or whatever underlying cause is improving, and now their ARDS is starting to resolve. Okay, but now we do not titrate. We stop titrating our pressure on the ventilator, how much pressure it takes to ventilate this patient's lungs, our mean airway pressure. Well, as the lungs get better, they get more stretchy. And now we get to the point where we're actually causing blood flow to be impeded because we're causing hyperexpansion and cutting off that blood flow that's going through there. So this could easily be causing now a dead space issue. So we went from having a shunt issue with ARDS to now a dead space issue with mechanical ventilation in excess of the patient's needs. This is why it's important for you to be thinking critically every time you go in to see that patient. You need to be thinking, where are they at in this disease process? Are they trending better or trending worse? Because here's the situation. Your patient on mechanical ventilation and ARDS, they could be getting better, right, as far as their lung pathology is concerned, as their ARDS might be resolving. But if you don't titrate their settings, or you don't have it so that the settings can be titrated for that patient as their compliance improves, then you're actually going to see a drop in their saturation, because both with a shunt and a dead space issue, they'll desaturate both ways, right? Because they don't have the amount of blood going through there. So you're going to actually see their blood pressure start to drop. You're going to see their saturation start to drop, and you'll be like, well, I thought their ARDS was getting better. It is, but now you're causing the trauma. You, the mechanical ventilator person, is causing the trauma, right? And that's why we got to be very cognizant of what's going on. What happened with their end-tidal CO2? Did their end-tidal CO2 drop? Well, that's a sign that now we've got this situation going on. We have volume distension, where we have damage to our lung tissue that we're causing, right? So this is why it's going to be important for you. Now, I love talking about the vena cava versus the heart compressibility. This is overlooked in a lot of areas in respiratory care, and so I'm hoping that you sort of are more cognizant of this. And I have a whole different cardiovascular lecture on the hemodynamic side effects of mechanical ventilation, and your Pilbeam mechanical ventilation book has a really good chapter on hemodynamics and mechanical ventilation, so I strongly suggest it, especially if you plan on working in critical care medicine. So you need to be aware of the blood flow through the heart. You need to know it goes through the vena cavas to the right atrium, through the tricuspid valve, through the right ventricle, through the pulmonary semilunar, and then from the pulmonary semilunar, here, let's do red, even though it's right, and then pulmonary semilunar valve into your pulmonary artery, and then pulmonary arteries to your lungs, and then from your lungs to your pulmonary veins that dump into your left atrium, that then go through the bicuspid valve into your left ventricle, that then hopefully goes through your aorta. And your aorta, you have your 3-branch arch. You need to know those. Common carotids and brachiiocephalic, left and right common carotid and brachiiocephalic. So here's the thing with neonate medicine. I know I'll preview it here for you. There's this shunt here from fetal circulation called the ductus arteriosus. So it connects the pulmonary artery to the aorta right about there where I drew that yellow section there. So that bypasses the lungs, because the babies don't need tons of blood flow to the lungs because they're not using their lungs yet. They're using mom's blood for oxygen and development. So they're sending a little bit to the lungs, but just for a lung development, not for oxygenation, right? So this is one of the fetal shunts. So here's the situation. You go to a delivery of a newborn, right? Someone's in active labor. It's a high-risk delivery. They want the respiratory therapist there because the last thing to develop on a baby is their lungs. What's the first thing they're going to need when they get out? Their lungs, right? And so it's a very critical transition from fetal circulation to extrauterine circulation. And so when we see this shunt here, it goes into this area, the aorta, from the pulmonary artery to the aorta. And what happens here is this is still open, especially in premature babies, And that means all this blood here is mixed. It's shunted. It's a mix of used blood now that the baby's outside. And so these two vessels that come off here and everything distal to that, so that would be your legs, right? The left arm, all that stuff, those all will have shunted blood. You're like, why do I care? And this is why you should care. So if we want to know how much oxygen is getting to this baby's brain, we're going to want to put the pulse ox, right? Because we want to see if the baby's got enough oxygen going to their brain on their right arm, because this area is not shunted. It's preductal is the term for it. It's preductus arteriosus, and that means we get the true saturation here, and this goes to the innominate artery that ultimately goes to the carotid that goes to the brain up here. And so we want to see how much oxygen is getting to the brain, because that's a pretty important thing, to get oxygen to the brain to keep the brain alive, right, to avoid that loss. So if you had a delivery, a high-risk delivery, a neonate, and we need to check how much oxygen is going to their brain to adjust their FiO2, to adjust their vent pressures, to look at how we're going to resuscitate them with the settings we have, you put the pulse ox on the right hand or the right wrist. And I hope this all makes sense to you. And I'm justifying to you just a little bit, I'm barely scratching the surface, a little bit of the importance of understanding the cardiac anatomy, right, and the blood flow. So I'm hoping that some of this comes across. When we're looking at pulmonary and cardiac together, this is going to be a very vital situation for you, especially if we're talking about things like a PFO. A patient has a hole in between the left and right atrium, or a ASD, right? I had most of my adults that I had to actually do the shunt equation on, right? I actually had to do the shunt equation to see how severe their shunting was, to determine if they needed surgery or not, or how aggressive to be with their current ventilator therapies and ICU therapies. Almost every one of them that I had to calculate was a hole, they had a PFO. There was a hole in between the left and right atrium, which, remember, blood pressure is higher in your left atrium than in your right atrium. And so blood will be going from left to right, right? That's the pressure gradient. You have higher pressure in your left, and therefore it will push it over. So here, let me draw a little square heart down here, right? So we have blood going from the good side to the bad side, which means the pulmonary artery, not only is it going to get extra blood, it's going to get blood that's good blood, that's oxygenated blood, the blood that's coming from the lungs. It's going to get that sent over into the right side again, so it's going to recycle it. That means our pulmonary blood volume, right, this is a weird pulmonary artery that I'm drawing, is going to increase, right? That causes pulmonary edema, right? This is a left to right shunt. And that pulmonary edema decreases surfactant in your lungs no matter how old you are. 5 seconds old or 95 years old. It will cause pulmonary edema, which will then dilute your surfactant, which will then make it harder for oxygen to get into. It'll give you atelectasis, it'll decrease your compliance, it'll make it harder for oxygen to get into your bloodstream, and therefore then they will start to notice those physiologic side effects, right? So not a good thing either way. That's why their shunts were well over 30% in these patients. Especially if a patient has cor pulmonale from severe pulmonary disease, then the pressure is going to be higher on the right side than the left side, and now you got shunting, a right to left shunt, that where we're sending bad blood into the good side, right? That's a true shunt, and no amount of FiO2 increase is going to help with that. So I hope you're getting the seriousness of understanding the physiology and why I'm going to stress it for you. So please go through the blood flow of the heart, understand it, understand where the valves are. Like I said, understand which valves are open during systole, which ones are closed during systole, which valves are open during diastole, which ones are closed during diastole. This is going to help you because, especially if you think a patient might have pulmonary hypertension, like hypoxic vasoconstriction, hypoxic pulmonary vasoconstriction, you're going to hear a loud pulmonic shunt with the cardiac cycle, a loud dub, right? You're going to hear that loud sound, and so that's going to tell you there could be an issue with hypoxic pulmonary vasoconstriction, because now there's a lot of back pressure. Right, now there's a lot of back pressure on the pulmonary artery, and then that's now putting a lot of pressure on that valve and a lot of pressure on the right ventricle. Our heart's having to work harder, therefore we might see more things like PVCs and all this other stuff. We might have an increase in our cardiac workload, which in some of these patients is not a good thing, right? They might already have pre-existing cardiac disease. All right, I'll get off the horse, so we'll move to the next slide. All right, why is it important? Heart sounds are great, but they're very subjective from person to person out there. A heart sound can vary. Someone could hear a gallop and a rub or a murmur, and another person can listen to that same patient and not hear it at all. And that all goes to training and experience and all that stuff, and also equipment a little bit there. But it's a little bit more subjective just going by heart sounds. When we look at hemodynamic monitoring, it's more objective. We know the pulmonary artery pressure. We know the pulmonary vascular resistance. We know the right atrial pressure. We know the central venous pressure. So we can evaluate that appropriately. So the sickest patients in the hospital need hemodynamic monitoring. It gets rid of a lot of subjective equipment, and it sort of tells us also where the issue is, right? So we'll see cardiac monitoring in ICUs, but you also see them in other parts of the hospital as well. Your cardiac step-down units, emergency department. If you want to work emergency department, man, I encourage you big time to get into hemodynamics. That will be a huge advantage that you will have over a lot of other practitioners out there. So when we're looking at all these pressures, we're going to break them down to pretty much like right-sided heart pressures and left-sided heart pressures like we did with disease class, right? So your right-sided heart pressures are going to be like your CVP, right atrial pressure, your mean pulmonary artery pressure, right? Your left heart pressure is going to be like your pulmonary capillary wedge pressure. And then like systemic vascular resistance. There's more than this. This is just me sort of giving you a little preview here. You're going to look at other things like your cardiac output can be affected here. You also have things like your left ventricular stroke work index. And then you also have your right ventricular stroke work index, but that's over on the right side of the heart. So when we're looking at this, why do I care about the right and left heart pressures, right? That's what you're ultimately hopefully asking. Where's the application? Why do I need to know what all those mean and which ones are right-sided, which ones are left-sided? Because it can tell you where the problem is, right? I can say, yeah, your engine sounds bad, but if I can't tell you what part of your car's engine is bad, then it's useless because you don't know what to replace. You don't know where the problem lies. So if you can put in a SWAN, you can put in a CVP, you can put in and see where the problem is, then we can work that problem. We can rule out something else, and we can actually be more expedient about working the actual problem that's going on. So let's do an example here real quick. I know I'm using a lot of time, but I see a lot of value in hemodynamics, and especially we're looking at this. Okay, let's say over here, I'm going to draw a pulmonary artery, and we're going to draw the fancy square heart here. All right, I have a patient that has hypoxic pulmonary vasoconstriction. Let's say they have severe ARDS. Okay. So they have hypoxic pulmonary vasoconstriction. That means blood is going to back up, because what happens when you have a 4-lane highway and then there's a car accident? Is it still going to be a 4-lane highway, or is it going to slow everything behind it and build up traffic behind it? It's going to build up traffic behind it. So the way to get through is a lot more narrow, right? And so the traffic is going to be backed up a lot behind it, and flow going past that area is going to be very low. So if I have hypoxic pulmonary vasoconstriction, what happens to my pulmonary artery pressure? My mean pulmonary artery pressure increases. Because this pressure is increasing, we have this backup. What happens to my right atrial pressure? My right atrial pressure also increases. What happens to my CVP? My CVP will also increase. So I know if we check on this patient, if we float a SWAN and we see that their mean pulmonary artery pressure is high, then we can look for reasons why they have hypoxic pulmonary vasoconstriction. So on a blood gas, right? What's their PaO2? What's their saturation, right? What's going on there? Hopefully that all made sense to you. All right, so let's do another example. I know I love this stuff. All right, we have a patient who has, and I'm not going to tell you what they have yet. Their right-sided heart pressures are all increased. And we also have an increase in pulmonary capillary wedge pressure as well, which is a left-sided pressure. We have a decrease in our cardiac output, but our SVR, our systemic vascular resistance, is normal. Our left ventricular stroke work index is increased. So we have an increase in our right-sided pressures, increase in our wedge pressure, increase in our work of the left side of the heart, like that ventricle is working hard. Our cardiac output's lower, and our systemic vascular resistance is normal. So what does this tell you? Where is the car accident? Well, in this situation, we know we're not squeezing lots of blood out. Our cardiac output is low. So that means that we know that our issue, or where the accident is that left ventricle, because past it, our SVR would be distal, right? Would be past it. Our SVR is normal. So we know the area behind the normal is causing the car accident, right? That's where the accident is, and everything behind it is backed up. So I know that I have a failing left ventricle then. That's why my pulmonary capillary wedge pressure is increased. That's why my mean pulmonary artery pressure is increased, right? Because there's a backup. That's why my right atrial pressure is increased. That's why my CVP is increased. All of those are increased because my left ventricle isn't efficient anymore. So it's important, if they float a swan, or if we have different ways non-invasively to look at this, like with echocardiograms and things like that, then you can be that much more valuable. You could be like, okay, let's work the problem. We know that this patient looked like they were in ARDS. However, there is evidence of left ventricular failure, so let's work on the ventricular failure part. I hope this all makes sense to you. So the sickest patients in the hospital need you not only to look at the monitoring, but to be able to think intelligently about what you are seeing. Not just look at the ECG and look for PVCs and all those other things, but I want you to also be looking at their pulse pressure. I want you to be looking at their heart rate. I want you to be looking at what happens when you change mean airway pressure on the ventilator, when you're increasing tidal volume, when you're decreasing tidal volume, when you're increasing PEEP, when you're decreasing PEEP, when you're increasing I time, when you're decreasing I time, when you're changing anything that affects mean airway pressure. You should be looking at their pulse pressure. You should be looking at their heart rate. You should be looking to see hemodynamically, is this acceptable, right? Not just look at their lungs, not just look at the saturation, not just look at the blood gas, but look at their hemodynamics also and see if that change is acceptable. Because if you increase the workload of the heart, is that patient in recovery mode, or now is their body working harder, right? So let's go on to the next screen. All right, so heart structures, you do need to know those. Pressure in the inferior vena cava and superior vena cava should be low, right? That's the venous return. Remember, pressure goes from a high to a low gradient. And so the pressure in your vena cava should actually be the lowest there is in all the veins. So compared to the veins in your legs, or compared to the veins in your arms, the vena cava should actually have a low pressure, because we want blood flowing from high pressure to low pressure. That's how physics work, right? And so your vena cava should have the lowest pressure. Can we measure this pressure? Absolutely, right? That's what a central line can do. We put a transducer on that central line. We can look at vena cava pressure. This pressure will increase as it enters the pulmonary artery, because why? Why will the pressure increase as it enters the pulmonary artery? Well, you have the right ventricle squeezing blood to the pulmonary artery, so that pressure will be higher because it just got pumped, it just got squeezed, it just got through something that's going to give it more energy to distribute through the lungs, right? The pressure in the left atrium will be lower than the left ventricle, right? So this is where we're going from a high gradient to a low gradient, right? As you know, as we go from the pulmonary capillaries, where it picks up the oxygen, gets rid of the CO2, where we coming from there, those are very small vessels. And as we get to the pulmonary veins, remember the pulmonary veins are larger, right? According to Poiseuille's law, if we have a larger diameter vessel, then there will be less pressure, right? And so when we go through there, it'll be that less pressure. So the atria will be lower than the left ventricle. Therefore, the pressure in the left ventricle is the highest. This is where we have to squeeze hard enough not to distribute blood to our lungs. That was the right ventricle. But we have to squeeze the blood hard enough to distribute blood throughout the entire body, including the head, right? So the left ventricle is going to have the highest pressure. It has the hardest job because it's got to distribute blood throughout the whole body, and that's one of the reasons why it's important to look at left ventricular function. If that left ventricular function is low, right, we have a sick left heart like CHF, then that's going to be a big issue because now we're not going to be distributing blood throughout the whole body. That's what we're looking at with multi-organ system failure. The inability to distribute blood is one of the big reasons for multi-organ system failure, right? And you can contribute to this. Let's say you're impeding venous return with too much mean airway pressure, then you're not going to have a lot of blood that goes to the left ventricle. Therefore, you can actually cause poor kidney function and things like that. You need to be cognizant of these other organ systems. What's going on with their LFTs? What's going on with their renals, right? Where are they at with their BU and creatinine? Where are they at with their urine outputs, with their I's and O's, so on and so forth, right? This is where you're going to have to understand that. I remember a statistic that the giraffe has the highest blood pressure of land-dwelling mammals because it's got to send blood all the way to its brain, right? I don't know how true that statistic is. I'll have to look that up, or maybe one of you can tell me. But we're looking at that left ventricle playing a key role, and that's something that we need to protect, is how much blood gets to the left ventricle and how effective that left ventricle is. So you need to pay attention to this. And this is all just assuming normal function. Right, things back up behind obstruction. That was what I talked about on that previous screen. So you need to remember that sort of pathophysiology. Where does the abnormality stop? Right, so like in that example that I used, that patient that was in left ventricular failure, their systemic vascular resistance was normal, but everything else was high. Their pulmonary capillary wedge pressure, their mean pulmonary artery pressure, their right atrial pressure, the central venous pressure, the right ventricular stroke work index, the left ventricular stroke work index, all those things were high because our accident or our issue was the left ventricle. So everything behind it was high. And I hope that makes sense to you. That gives you sort of an image to look at, when a mental image to think about when you go through this thing, sort of a logical procession of it. So you should be able to trace the blood flow through the heart. You should be able to tell me which valves are where, which valves are open during systole, which one are closed during systole. Same thing in diastole. You should tell me the major structures. You should tell me, right, where the pressures are the highest, where the pressures are the lowest, right? All this information, I hope I've stressed to you the importance so far. So normals, normal 120/80 for arterial blood pressure, mean arterial pressure, not mean airway pressure, but mean arterial pressure, normally is about 70 to 105. And so when we're looking at mean arterial pressure, this is something that you'll see more common trending in critical care medicine as of me recording this. We tend to look at mean arterial pressures more than systole and diastole, because you can be in systolic heart failure, diastolic heart failure. That's a whole separate lecture. I'd love to lecture on that stuff, but that's not for this lecture. So we tend to go off of mean airway pressures. And hopefully you remember the calculation for this. It's your systolic plus your diastolic times 2 over 3, right? Because there's 3 factors, right, in the numerator. That's what gives you your mean arterial pressure. A normal mean arterial pressure is 70 to 105. Okay, that's great. So if the mean arterial pressure is 70 to 105, that's something I need to be taking account of. Both non-invasive and invasive blood pressure monitors will calculate this for you. However, I may ask you to calculate it, or you might get a question where you might have to figure out if their mean arterial pressure is in this area. So I expect to do that calculation, of course, because I just want to make sure that you understand the application. And hey, does this patient, are they hypovolemic? Do they need more fluids? Or hey, their mean arterial pressure is now 105, and now the next time I see them it's 110, and their heart rate's faster, and their pulse pressure is lower. Well, if your mean arterial pressure is increasing, and let's say it's increasing above 105, right? Let's say it's steadily increasing, and also the heart rate's increasing, and their pulse pressure, which is the difference between systole and diastole, right? If that's decreasing, that's a sign your stroke volume is going down, right? So if your stroke volume goes down, remember cardiac output equals stroke volume times heart rate. So if my cardiac output, my stroke volume decreases, then who has to compensate to sort of keep a good cardiac output? My heart rate has to increase, right? So stroke volume decreases, heart rate increases. If heart rate decreases, in theory, your heart's supposed to increase stroke volume, right? That's how it's supposed to work. So I see the mean arterial pressure increasing. So is their heart rate. And their pulse pressure is decreasing, which is how we sort of equate to the left ventricle and stroke volume. Then that's a sign that their heart's not squeezing very well. And so that could be our problem. That could be something we're doing from a positive pressure standpoint. Right? So this is why it's important to look at this. Now I go and titrate my ventilator where I decrease mean airway pressure of some sort, where we decrease tidal volume, we decrease PEEP, we do something like that, we decrease I time, we do something that decreases mean airway pressure or compressibility, and we start to see the heart rate go back down again, we start to see their stroke volume increase, then those are positive cardiac effects that we're seeing. I hope that's making sense to you. Their end tidal CO2 increases as well. Those are all signs that we're seeing better perfusion. We're seeing better cardiac effects with those changes in mechanical ventilation. Right? Pulse pressure, I just talked about a little bit. Pulse pressure is the difference between systole and diastole, and usually it's about 30 to 40 millimeters of mercury as well. This is something important to look at because we're looking at pulse pressure sort of equating to stroke volume, or how much is squozen during systole, how much sort of comes out during systole in pressure, right? We're not looking at volume, but we're looking at how much pressure is created between systole and diastole, right? So if we see this value decreasing, that's a sign the left ventricle could be sicker, or we have poor blood flow going to the left ventricle, right? If we see this value increasing back up, that means we have now better blood flow going into the left ventricle. We have better squeeze of the left ventricle. So if we give a patient that's hypovolemic a liter of fluid and their pulse pressure goes from 20 to 30, then they were hypovolemic, and now, right, we got the patient to a normal pulse pressure, we got them to a normal stroke volume, therefore their heart rate will start to decrease. You'll start to see the heart rate go down. We're not talking about bradycardia, we'll just see it go from 120s to maybe 95 to 100. Right? So you can sort of see why you need to be looking at pulse pressure. You need to be looking at mean arterial pressure. You need to be looking at your systolic and diastolic. If they're in diastolic failure or systolic failure, like I said, it's a whole separate lecture, but I'd love to go through it with you guys at some point. All right, let's talk about arterial lines, and then we'll talk about central venous lines, and we'll talk about swans. Arterial lines are they're great for hemodynamic instability, and that's actually one of the indications. So if I ask you which of the following are indications or which of the following is not an indication, that's free game. So hemodynamic instability is usually your #1 indication for these. If we have to give a patient vasopressors, or we have to, if they're in severe hypertension crisis, then we have to give them drugs to decrease the blood pressure. Of course, that would also be an indication for an A-line. So any hemodynamic instabilities, an A-line is going to be very helpful and useful in seeing how this patient responds and being therapeutic early on. Frequent ABGs, especially in patients with severe ARDS or severe lung compromise, if we have to draw cereal gases on them, then that's going to be perfect. Even in the exercise stress test, we talked about doing ABGs at each of the different levels with a multi-stage test. That was an indication for an A-line in those patients, right? Instead of poking them multiple times, they get one poke, and then they have an indwelling catheter for the remainder of the test that we can just draw gas on at each 3-minute interval. If they're hypotension or hypertension, we're talking about severe here. It's a great thing because then we have a continuous hemodynamic monitor. Remember, our non-invasive blood pressures cycle maybe every 15 to 30 minutes or so. It depends on what we set it on, but that in the meantime, that patient could be developing something pretty serious we may not catch. Therefore, an A-line, which gives us continuous monitoring, may be a lot more effective. It's like doing an ABG versus to look at saturation versus a pulse ox to look at saturation. One of them is going to give us that continuous trend. The other one's going to be very intermittent and a snapshot, right? So you need to look at it for severe blood pressure issues. ARDS, of course, for both of these, because a lot of these people in ARDS not only will have ventilation and oxygenation issues for frequent blood gases, but they most likely, especially since the #1 cause of ARDS, according to your disease book, is sepsis, are also going to have significant hemodynamic instability as well. So there's a reason why this is going to be a good thing for these patients. And it also can help us look at things like left ventricular function and all that stuff. And we'll get into that a little bit later. Like I said, if anybody's on a lot of cardiac medicines, especially post-op hearts, they're going to be on art lines, and we want to be able to make sure that their heart is still getting good value. So drugs, I know you guys are in advanced pharm right now. These are good things to go over. Negative inotropes are inotrope and chronotrope. These are two terms you need to be familiar with. Inotrope is how strong an inotrope is the strength of the squeeze of the heart. So if it's a negative inotrope, it's going to decrease the strength of the squeeze. So let's say we have someone that comes in and their systolic blood pressure is 200 and their diastolic pressure is 110. That's a severe hypertension, right? And let's say they have a lot of symptoms with it. It's a crisis, right? Emergency, right? So this could easily cause that patient to have a lot of bad issues with that severe hypertension. Eclampsia can be one of them, especially if we're looking at someone that's pregnant. So that's one of the things that we could do is give these patients a negative inotrope to help decrease the squeeze. This helps to decrease blood pressure, right? It's a hypertension medicine to get rid of hypertension, hopefully. So negative inotropes. Amiodarone is just a drug in this category. I just want to give you an example of drugs in these different categories. So if you're looking at MARS when you're in ICU clinicals, you'll see, oh, amiodarone, that's for high blood pressure. Well, how high was their blood pressure, right? Well, what's the indication there? So if that's a negative inotrope and it decreased blood pressures, this one's a positive inotrope, and therefore it would increase blood pressure, right? So it increases the squeeze. Dobutamine, dopamine, we can use fluids, though of course those are not considered inotropes, but that would help increase blood pressure. But there's lots of different things we can do to increase blood pressure, right? But dobutamine is just an example that I put in there. So positive inotropes increase blood pressure, especially if people are hypotensive. Dopamine, dobutamine, vasopressin, norepinephrine, epinephrine, right, will all be in there. We could also give vasodilators. Nitroglycerin is a category that's in here. So if we have someone that has hypoxic pulmonary vasoconstriction, giving them something like nitric oxide or an inhaled vasodilator like Flolan or something like that, that will help pulmonary capillaries vasodilate. Technically, they're endothelium-derived relaxers. In other words, they'll relax the endothelium, therefore allow for dilation. Sort of like the difference between albuterol and Atrovent. You know how Atrovent is a backdoor bronchodilator because it lets the areas relax. Same thing here with like nitric oxide is that it lets the pulmonary vessels relax, right? And so people call it a pulmonary vasodilator. It does have a dilating effect, but it's actually an endothelium relaxer. Sorry, got a little too technical with you there, but there you go. So vasodilators, like nitroglycerin, like that's what they use for ACS, heart patients that are thought to have issues with blood flow to the heart. That will help vasodilate to get more blood flow, hopefully to the heart muscle, until we can clear it in cath lab and so on and so forth. So that can decrease blood pressure, right? So this is to decrease blood pressure. So that's why you have to watch it with nitro. You don't want to overdo it because that will cause too much vasodilation and their blood pressure can significantly drop. And it but like I said here, in the case of like an ACS where someone has a blockage, it will actually improve perfusion to the muscle, so it can actually benefit patients. So you just got to watch out that it could decrease their blood pressure as well. Vasopressors, be very familiar with this category in critical care medicine. Norepi, epi, vasopressin, especially, I'll have patients on all three of them. Now, this is a sidebar. You don't need to memorize this for my purposes, but if you see patients on all three of these, their prognosis is usually very poor. Now, I'm not saying to give up on these patients, but just understand the level of sickness this patient's on. That's what I want to get across to you. If you see these drugs hanging, right, then that's a sign that this patient's hemodynamic stability is very, very poor. They have very low blood pressure, and this is what we're currently doing to try to get that blood pressure up. So this means by you touching their ventilator, by you affecting their mean airway pressure, you can have a significant effect on what's going on with their cardiovascular function. Hopefully I'm getting that across to you. So it's important you recognize these drips. You know if these patients are on these medicines. If you know they're on one of these or all three of these, then you need to be aware of, hey, what are my mean airway pressure implications to the vasopressors? I've had patients where they had an end-tidal CO2 of like 12. And their PaCO2 was 60. That's a huge dead space issue. One of the things I did, and I'm not saying to do this in every case, right? Please take that, right? I'm not saying to do this in every case. We would decrease their mean airway pressure and their end-tidal CO2 would start to grow. It would go to, let's just say 25. Pretty big change from 12, and therefore they would have more blood flow going through their lungs, because I'm not compressing their pulmonary capillaries. And I'm not compressing their vena cavas, and now there's more blood flow going into the left side of the heart. There's more blood that's picking up oxygen, and now there's more blood flow going to the left side of the heart. The left side of the heart is now able to squeeze more blood out, and therefore we can actually decrease the amount of vasopressors these patients are on. Therefore, the peripheral vasoconstriction that happens with this, and even blood flow to the kidneys, can then improve. We can have better urine output. We can have better liver perfusion. We can have better perfusion to their brain. And we can start titrating some of these drugs. So little changes like this can make a big difference in your patients. But you got to be looking at little things like, hey, end-tidal CO2, what does that mean to my blood pressure? Not just ventilation, but what does it also mean to my blood pressure as well? Right? If a patient's on a beta blocker, they slow a beta stimulation, and therefore they do what to cardiac contractility. If they slow beta stimulation, therefore they will decrease cardiac contraction, right? That will help with high blood pressure. That's why people will be on beta blockers like labetalol at home, right? It'll block that beta stimulation, that will decrease their heart rate and their blood pressure. People that have anxiety issues, I don't know if they still do it or not. They used to prescribe beta blockers for those patients that have panic attacks, so on and so forth, to help with that type of situation. Another category for hypertension, these are all hypertension drugs, right? Calcium channel blockers, ACE inhibitors, diuretics, all these things in this category here, in this bracket that I'm drawing, are things to decrease blood pressure. Right? Calcium channel blockers reduce conduction, right? Because we're blocking the calcium channels. Hopefully you remember the electrolytes that go into the cardiac cycle. They reduce conduction and dilate arteries. Okay, why do I care about this, Derek? Well, here's the thing. One of the things that you might do in cath lab as a diagnostic respiratory therapist is do what's called a vasoreactivity study. Okay, you're like, Derek, I've never heard of that before, right? A vasoreactivity study, and you can look this up, is where we take a patient, we'll go to cath lab, and they're a healthy patient, right? They're usually an outpatient that come in for this procedure. We'll take them to the cath lab, and they'll float a Swan Ganz, a balloon-tipped flow-directed catheter is the word that the board exams will use. They'll float that in the pulmonary artery, and they'll look at central venous pressure, we'll look at right atrial pressure, we'll look at pulmonary wedge pressure, we'll look at mean pulmonary pressure, right? We'll look at all those pressures. You're like, okay, that's great because it's very diagnostic. Then we can see where the issue is. But when we're doing a vasoreactivity study, you go in there as the respiratory therapist and you put nitric oxide on this patient. So they're breathing nitric oxide. So this is usually done through like a couple one-way valves and an anesthesia mask, and you're holding tight. You usually start either 40 or 80 parts per million. And you hold nitric on their face, and then they'll breathe in this nitric for a couple minutes. Remember, the half-life is like 10 seconds for nitric oxide. And so pretty quickly, you should see a change in their pulmonary artery pressure, right? If we're causing pulmonary vasodilation, then we should see their pulmonary artery pressure decrease. Makes sense, right? We're dilating everything downstream, therefore there's going to be a lot less back pressure. And so if we see the mean pulmonary artery pressure decrease, then we know they're vasoreactive. In other words, they would respond, their arteries would respond, they're vasoreactive to a calcium channel blocker. What happens if they don't respond? What happens if their pulmonary artery pressure doesn't do it at 40 or 80 parts per million? Well, that means that they're not vasoreactive, and that can happen over a long period of time of scarring with arteriosclerosis. So if they've had hypertension, athero and arteriosclerosis, if they've had prolonged chronic hypertension, then they could have scarred their vessels enough to the point where they may not respond to calcium channel blockers. Then we know if calcium channel blockers will work for this patient or not. There's a diagnostic purpose for understanding calcium channel blockers, but also as a respiratory therapist, you might put some patients that have chronic hypertension. That's one of the reasons why you might want to know if this is in their history or not. Chronic hypertension, you might put them on ventilator, and let's say they put nitric on this patient. Let's say they want to give them a pulmonary vasodilator of some sort. We do it and we don't see much change at all. Well, that patient may not be vasoreactive because the chronic hypertension may have caused changes in their blood vessels where they don't dilate and contract near as much. They're not as vasoreactive because of the scarring that's gone on. Sort of like pulmonary fibrosis, the blood vessels, right? They're not going to be as reactive to changes than a normal blood vessel. I hope that makes sense to you. So that's one of the diagnostic things that you might be doing, and that they're looking ultimately for calcium channel blocker effectiveness or not. ACE inhibitors, they vasodilate. That's an antihypertension. Converting enzyme, angiotensin 1, it stops angiotensin 1 from converting into angiotensin 2, which then causes vasoconstriction and increasing of blood pressure. So it stops that conversion from angiotensin 1 to angiotensin 2, so that way it keeps their blood pressure low. So this is technically a vasodilator, but it's blocking something that's causing vasoconstriction. I hope that makes sense. And then diuretics get rid of vascular volume. Be very careful here. Diuretics, for a lot of RTs, they're like, hey, diuretics are my friend, and it can be from case to case. However, remember, diuretics, the most common one out there is furosemide, which is Lasix, and that's a loop diuretic, which works on the loop of Henle in the kidneys. And it can be powerful, but it can also, remember, when you get rid of sodium, you're also getting rid of, because all the diuretics, every one of the classes of diuretics, even the potassium sparing ones, not only do they get rid of sodium, and that's how they work, they get rid of salt, therefore water always follows salt, and that's what pulls more fluid off of the patient, but you're getting rid of electrolytes too. And so you can mess with their electrolytes. You got a patient already has bad cardiac issues, dehydration, things like that. You could be causing a lot of issues. Not only that, but you dehydrate a patient. You give them too much diuretics, you dehydrate the patient, they're going to go into metabolic acidosis. They're going to have big issues. You can mess with their GAP versus non-GAP big time with diuretics as well. So understand that when you see practitioners be stingy, be conservative with diuretics, they do that with the best interest of the patient in mind, and you should be on that category. Don't be like, we should give everybody 40 of Lasix. Don't be that person, right? They're going to be very conservative, usually like 10 of Lasix or 5 of Lasix, right? They're going to be more on the conservative side. You want that. You don't want large changes. You don't want large variations, because that will decrease vascular volume too much. And if you decrease not only their electrolytes, but their vascular volume too much, how much pressure is there in the pulmonary capillaries? Well, there's not much pressure at all. So are the pulmonary capillaries then more prone to collapse and getting less blood flow through there? Yes, which means they're more prone to a dead space process. That's why a patient in severe ARDS, in some cases, will give them a liter of fluid. Why would that liter of fluid help that patient in severe ARDS? As long as they're not positive, fluid positive, why would that help? Well, we're pretty much CPAPing and getting more perfusion to the lungs, and therefore we can pick up more oxygen, so that can actually increase their saturations as well. So a little half liter or a liter during your severe ARDS cases where their PaO2 is dropping below 55 or so, depending on hospital policy, can actually help a patient actually get better oxygenation. So be very careful with diuretics. Be very careful with hemodialysis versus CRT, right? Hemodialysis takes fluid off quickly. CRT, continuous renal replacement therapy, takes it off more gradually, and therefore less hemodynamic side effects. There's even a question on the adult critical care specialist exam where it's asking pretty much about which one's superior for a patient that's hypotensive. And you're going to pick CRT over hemodialysis every day because it's a slower pool of fluid than a fast pool of fluid with hemodialysis, right? So a hypotensive patient, don't pick hemodialysis. Hypotensive patient, don't give them diuretics. I'll say that again. Hypotensive patient, don't give them diuretics, because it sounds like I can give you a scenario where I might try to lure you down that road. Don't go there, right? I'm trying to get you, right? I'm trying to see if you remember this. Volume expanders help increase blood pressure, so that last bullet point there. Normal saline, lactated ringers, albumin. Hopefully you remember albumin too. It's a great thing. It's an intracellular protein that you have. If someone's low on albumin, they tend to third space. Right, they lose osmotic pressure, and they have third space that can include pleural effusions and edema, ankle swelling, right? All that stuff in their hands. I had a patient once who was having difficulty breathing. He was a respiratory eval and treat, and he was on room air, and he had difficulty breathing, and I was told by the rest of the care staff that he feels like he's having a hard time breathing, but they thought it was more psychological in etiology, the rest of the care staff that was taking care of that patient. And so I went in there and I listened, and the breath sounds were just super distant. Like I could not hardly hear the breath sounds. And I wasn't having a bad ear day that day. And so I asked about his labs, and they did an albumin, and it was very, very low. And so my hypothesis was that he had a pleural effusion because he had difficulty both inhaling, right? He could not get a breath in. He felt like he couldn't take a deep breath is what his statement was. I can't get a good breath is what he told me, which told me it was a restrictive effect. And so I asked about an X-ray or CT scan to look for an effusion, and I mean, hopefully down the road we could just do a bedside ultrasound or something like that. But and sure enough, he had a 3 liter on the left and a 4 liter on the right. So pretty significant bilateral pleural effusions because his albumin was low. So if we give someone albumin, it increases the protein in their vascularity, and therefore they can hold more volume in their vascularity. That would increase their blood pressure. Be careful, because where does the fluid come from if we give someone albumin? Well, it comes from their muscles and their tissues and all that stuff. So we could actually dehydrate their muscles and their tissues even though our blood volume increases, right? So you got to be very cognizant of that. All right, insertion sites for A-lines. Radial line is going to be preferred for the adults. You have better collateral circulation, less risk of infection. A lot more people are more cognizant of it. In a neonate, they're born with central access, central venous line and A-lines. They have 2 arteries and a vein in the umbilical stalk. And so babies, we can just put it right through the umbilical artery. one of the umbilical arteries that's there. Pretty straightforward. Usually with babies, most of the time they will only have that in for a couple of days or so. Brachial, femoral on the adults. Right, now we're back to adults again. Brachial and femoral are secondary sites. Femoral is a great option if your patient's on vasoconstrictors, on pressors, right? Because it's more centrally located, it's not going to be changed by vasopressin or norepi or epi drips. It's not going to be changed as much because when you give a patient epinephrine, it vasoconstricts, and which area is going to be affected most? Your distal fingers and toes and all that stuff are going to be affected most. So the more central the A line is, the better feel you have of how much blood pressure is in the core of the body, right? The heart, lungs, brain area. So the femoral in a hypotensive patient or a patient that's on a lot of pressors can actually be an advantage in that situation. I hope that makes sense. There's, in theory, you could do axillary and ulnar A lines. In my experience, so this is anecdotal, I have not seen those, but according to your materials, they are possible locations. All right, so the dicrotic notch, right? So this is the closure of a certain valve. Hopefully you remember this from critical care techniques. Please tell me you do. Please tell me you do. Please tell me you do. All right, so this is what we're looking at. The systolic peak and the diastolic peak. So we're seeing the difference between systole and diastole. And this can give you a lot of information about a certain part of the heart. It's in your books. I know it is, especially Wilkins. It's a certain valve. Pretty important valve. Right, it's going to tell you the difference between systole and diastole. So I like looking at this, looking for the dicrotic notch. And it can sort of tell you how strong the systole is versus the diastole. And then when we're looking at this, we could evaluate it in a visual way to look for a diastolic heart failure or systolic heart failure. Obviously, the systolic heart failure, you would have less of a peak, right? You'd see less of a less significant arch. So let me here draw it in. So instead of this nice arch here and then over here, you would have this sort of, it would be down here, right? So that would be a sign of systolic heart failure. Or diastolic heart failure, you'd have it, the dicrotic notch would move up, right? Because we're not having an issue. It's that end squeeze, it's that recovery. So this is a waveform that you can look at to sort of help tell you about the trending of their function as well. So it just gives you a visual representation. Besides, just like mechanical ventilation, we have those waveforms and graphics. Those waveforms and graphics just give you that visual indicator or way of looking at it without having to sort of think through the numbers as much. Does this equate to what I'm seeing with my numbers? Or if you see it different, then maybe that's an indication you might need to evaluate your numbers more seriously. So the waveform may change with respiratory cycle in the arterial lines. It shouldn't. Systolic and diastolic. Now, I will give you a scenario where you might see some change here, and that would be in your severe asthmatic patients, those status asthmaticus patients, where it causes pulseless paradoxis, right? That's where the blood pressure would decrease during inhalation and increase during exhalation because there's so much air trapping, and that's why I'm giving that severe asthma as a case. If there's severe air trapping going on, let's say a patient's breathing fast on a ventilator and they're air trapping, they're not getting that full exhalation, then you might see more changes in their arterial line waveforms. That's a bad sign, right? That's a sign of air trapping. That's a sign of pulseless paradoxis, right? That can easily be causing our blood pressure issues there. But normally, should not change much with respiratory cycle at all. The dicrotic notch represents the aortic semilunar valve. Notice that's underlined. Notice that's something I asked you about in the previous slide. Yes, the aortic valve closure. So when a patient's having severe hypertension issues or the SVR is high, things like that, you might hear a loud aortic valve shut if you want to go through heart sounds. I love going through heart sounds because they can give you a lot of information about pulmonic and as well as aortic sounds. No notch equals a dampened tracing, which means your numbers there may not be the most reliable. So it's not something that we can still use it to pull like gases and stuff off of, but it's probably not a reliable method of looking at blood pressure. So if we need the blood pressure to be monitored, then we probably need to switch the site. Measured values are lower than actual values if you see a dampened tracing. Therefore, that's something we can see what looks like a normal value, and the patient actually might be hypotensive, have low blood pressure to their kidneys, low blood pressure to their brain, so on and so forth. Not great, right? So we should not use that because that patient could be hypotensive compared to where we're seeing them. So if you don't see that good tracing, then that means that reliability of those numbers could be compromised. I hope that makes sense. The other thing here, you might not see a dichrotic notch. That's why I say it's important to know if you have a patient that's coming back from heart surgery, if they had an aortic valve issues, right? If they have aortic valve prolapse or something like that going on, you may not see a good dichrotic notch, because if it's prolapse, then you're not going to see that complete closure, right? The semilunar valve, the aortic semilunar valve, doesn't close completely, and therefore blood backing through back into that left ventricle with each diastole, and you're not going to see a good notch there. So that's why it's important to know if they had a an aortic valve issue as well. Complications from arterial lines: embolism, thrombus, spasms, easily. The cool thing here is, I think I told you guys this during critical care. I used to go into my patients with radial A-line rooms, and I would touch their hand, and I would say, "Hello, I'm Derek with respiratory care. I'm here to look at your breathing machine, and look and all this other stuff." And the whole time I was touching their hand, I was sort of feeling for how cold their hand was, looking at the sort of the color, and then sort of like a weird way of looking at cap refill, right, when I took my hand back off of their hand. So I'm looking for that perfusion there, right? Because they can't tell me they're in pain or they have numbness or tingling or anything like that. So as far as a bedside assessment, that was my way of sort of seeing, are we having a complication with that A-line distally, right? I hope that makes sense. A lot of the family members thought it was very sweet that I would do that, which I thought was interesting. I don't think they ever knew that I was using it for my own bedside assessment. I think they thought it was a good gesture on my part. But that's a whole separate thing. Just understand ischemia, hemorrhaging. You can lose a half liter of blood a minute with the disconnecting. So that's an advantage of a radial line versus a femoral line, because a radial line is not usually covered up by bed sheets. Not usually, right? It's usually out in the open. More people are looking at it. The femoral location, most people are not looking at that. Usually it is covered up by a towel or a bed sheet or something like that. And so it's hard to evaluate if something like that comes disconnected. And then the longer these lines stay in, the more risk of infection you have, and that's why that's important to know what day their lines are at. Hey, is this day 3 or is this day 13, right? Should we be pulling that line? Especially if they start to look at things like they're starting to run a fever, we should probably pull and culture it, right? And then either put it in a different one in the other radial site if we need one still, or can we get what we need non-invasively? Interpretation, if someone's hypovolemic, cardiac failure, or if they're in shock of some sort, or if they have a massive vasodilation like sepsis, or they got too much Diprivan, those will all cause the blood pressure to sort of be low, especially if the Diprivan's given a little too much. So those are all things that you want to be looking at. If you do see low arterial blood pressure, what happened with their volume status? Is there an active bleed out, or are we in cardiac failure, right? Do we need to get an echo to look for cardiac failure? Are they in shock of some sorts? Do we need to start looking at the different types of shock and which one this patient's most likely in? Is there vasodilation going on, right? What's their temperature? What's their central line pressure? So on and so forth. Do we just give them a medicine that can affect their blood pressure, like sedation, like a Diprivan type situation, where that can actually drop their blood pressure? So be cognizant of that. What led up to that situation, or what are my differentials? Heart failure, shock, vasodilation, hypovolemia, right? What's going on with this patient? Signs, if it's increasing, we could actually have better vascular volume going on. Let's say we give him a liter of fluid. Let's say we give him some albumin. Let's say, right, something like that happened. Better vascular volume. Sub-PRBCs, sympathetic stimulation, fear, pain meds, or pain. I had a patient that was, this is a pediatric ICU patient, and he was on a ventilator. I think he was like 14 or something. He was on a ventilator. He was paralyzed and sedated, so chemically paralyzed and sedated, because he was in a severe situation. And his heart rate started increasing and increasing and increasing. His blood pressure started increasing and increasing. So both of those were going up. And so the nurse was like, I don't know why they're going up, right? He's starting to run a little bit of a fever, like a low grade. So we were thinking it could be stress, but then I asked about what could be if they were on pain meds or not, and the nurse had stated no, because or their pain meds were very, very low for one reason or another. And so my question was then, could this be a sign that they might need whatever pain meds they are getting? Because just because you're chemically paralyzed and sedated doesn't mean you don't have the pain response, right? You don't have the pain receptors going on. So they still need those pain receptors. They still need that control for their pain. So little things like that can give you a good hint that they might even be in pain or something like that, or fear and anxiety. They might be waking up and their sedation might be a little too low as well. You'll see that where patients are paralyzed and their sedation somehow wears off or becomes low. If you were paralyzed and aware and you couldn't move, and something was jammed into your trachea, right, the ET tube, you would be scared too, right? And so that's that whole situation of making sure you sort of understand what can go into that. So they might have sympathetic stimulation that's causing that blood pressure to go up. Improve vessel tone, especially if their sepsis is getting better, vasoreactivity is getting better, right? All that stuff's improving, then that might be a sign we might be able to decrease our vent settings and so on and so forth, our pressors. One of my favorite things was actually seeing a desaturation. I know this sounds weird. One of my favorite things is we'd have a patient that's in very bad multi-organ system failure, and the renals are in failure, right? They're in renal failure, and we'd start to see them desaturate a little bit, right? They'd go from like 94% to 91%. And I'd be like, oh, that's interesting. And I would inquire about their urine output or whatever. And sure enough, the urine output was improving, or some sort of renal indicator was improving. And I would be explicitly happy, right? I would be incredibly happy, because that tells me the kidneys are back online again. That means they're using more oxygen. We're having more oxygen consumption because that organ is now working. It's online. It's requiring that energy, and that's why they desaturate it. And so to me, that was always a good sign. I loved it when that happened. And of course, I looked weird for being like, yes, they desaturated a little bit, right? But for me, like, I seen that exchange, that physiologically my patient's getting better. That's turning a very good and beautiful corner, right? So hopefully you sort of see that improved vessel tone, and vasopressor medications are working. That's all signs that all things that could increase their blood pressure. All right, pulse pressure. I already talked a little bit about this. A pulse pressure reflects the left ventricular stroke volume, so how much it squeezes out. So pulse pressure normal is, remember the normals? Well, we'll go over it in a second here. A pulse pressure less than 30 millimeters of mercury shows poor left ventricular stroke volume. So it's the difference between your systolic and your diastolic, right? That's pulse pressure. So if we have a pulse pressure that's less than 30, then that means the left side of the heart's not squeezing too well. for some reason or another. Either there's not enough blood in there, or the muscle itself is sick. Something's going on where it's not squeezing that out as well. So pulse pressure is looking at sort of one way of looking at the health of the left ventricle, right? So stroke volume and arterial compliance is what we're looking at here. That pulse pressure will change with systemic vascular resistance as well. So if I give a patient a vasopressor, like a epinephrine drip, or norepi, or vasopressin, right? We give them a pressor drip. I'm increasing systemic vascular resistance because I'm vasoconstricting. Therefore, I should see a lot more back pressure and an increase in my pulse pressure, right? I hope that makes sense to you, right? So that's just one thing that can happen. If my patient somehow is running a massive fever and they vasodilate for some reason, then my pulse pressure may go down because my arterial compliance increased, right? The blood vessels are larger, and therefore my back pressure is lower, therefore my pulse pressure is lower. I hope that makes sense. So pulse pressure, it's just the difference between your systolic blood pressure and your diastolic blood pressure. No fancy calculation there, just subtract the two. Normal is, we said it before, 30 to 40 millimeters of mercury. Less than 30 shows poor left ventricular stroke volume. Those are numbers you need to remember. I will ask you that again. Less than 30 millimeters shows low ventricular stroke volume. If a pulse pressure increases, the patient may have had hypovolemia. So if I give you a scenario where a patient comes in, they're in a tachycardia, let's say their heart rate. So here's the situation. Mentally put yourself in your Pima stethoscope. All right, patient comes in and their heart rate is 125. Their respiratory rate is 40. Their pulse pressure is 25. Now, I won't tell you their pulse pressure. I'll make you actually do the calculation systolic minus diastolic. Because I'm that type of person. Because they won't tell you this in real life. You have to know that. So, realistically, right? So, they're tachycardic, tachypnic, low pulse pressure. And let's say they had flu-like symptoms, they've been having massive diarrhea, so on and so forth. They're losing lots of fluids. They haven't been drinking much, right? So this patient may be hypovolemic. Well, if we give this patient, let's say, a liter of fluid, right? We give them a liter of fluid and their pulse pressure increases, then they were probably hypovolemic, because if we give them this fluid, right, and their pulse pressure increases, that means it was that vascular squeeze. It was nothing to do with their systemic arterial compliance. It was all to do with how much blood volume they have. So if we give them this liter of fluid, and now their heart rate goes to, let's just say 95, and their respiratory rate goes to 30. My pen's not working very well. The respiratory rate goes to 30, the heart rate goes to 95, and their pulse pressure is now 35, right? Then we know that this patient was hypovolemic. That was their big issue. They needed that vascular volume. They were losing volume without replacing it, right? Mean arterial pressure, I know we've already talked a lot about this, but mean arterial pressure is normal, is 70 to 105 millimeters of mercury. Please remember that. I will ask you that in many different ways. You need to memorize it. That's something that you need to know for critical care medicine. Just in general, they'll even titrate pressors to mean arterial pressures, not systolic and diastolics. So as I'm recording this anyway. Perfusion to vital organs is inadequate if the mean arterial pressure is less than 60. So just like you don't like PaO2s less than 60, you don't like a MAP less than 60, a mean arterial pressure less than 60. That means your perfusion to your kidneys, your liver, your brain, your heart muscle itself are all compromised. That's why we try to keep a MAP of at least 60. And above. Now, there's a case where we try to keep the mean arterial pressure lower, and that would be in the case of like an aortic aneurysm, or situation where we want to keep the blood pressure low to reduce pressure on that type of site. So there's like English, like there's always an exception here or there, but Generally, we try to keep it above 60, right? So normal 70 to 105, keep that map more than 60, but less than 60, we have inadequate perfusion to vital organs. So the big thing here is patients that have shock. We're going to be looking pretty closely at their mean arterial pressure. So because the big thing here is tissue perfusion, right? If we're not perfusing the tissues like the brain, the heart, the kidneys, the lungs, right, all those good things, then what's the point, right? So we need to make sure that we get oxygen distribution to those organs, and that's the distribution to the organs is not done with the lungs, it's done with the heart. And so the mean arterial pressure can tell you, hey, we're actually getting perfusion to the distal portions, which means we're sending oxygen there, which means we might help reduce metabolic acidosis, right? Especially if they're in a metabolic acidosis from from a hypoxic injury. Calculation, I will expect you to do this, of course. Systolic plus diastolic times 2/3 is the one that I use. There's another one here from your Wilkins. You can do a third of your pulse pressure plus your diastolic pressure mathematically. They're identical, so have fun with that. Be careful if your pulse pressure is, or sorry, mean arterial pressure is starting to climb, like I said earlier. Let's say it's at 105, and then it goes to 110. And you start to see with this the heart rate steadily increasing. And you see a decrease in their stroke volume. What's going on with this patient? Right? They're spending more time in diastole, or there's more pressure in diastole, and odds are here this patient is heading into heart failure. Right, so a high mean arterial pressure is not a good thing either, especially if you see these symptoms arise with it, whether they get tachycardic, their pulse pressure starts to decrease. You're looking at a possible case of heart failure, and so that's something you might want to look at sooner than later on these patients. All right, here's some questions for you to answer. These are me just asking you. Just sort of see where you're at. These are you questioning yourself, sort of, and seeing what have I gotten out of this. What is the preferred arterial line site for an adult? Femoral, brachial, radial, or ulnar? Yeah, which one's preferred? Not which are all optimal sites, but which is most preferred in adults. And then, hey, what's most preferred in a kid? Bonus question. A neonate at birth. Which condition would not be indicated for an arterial catheter? Sepsis, cardiogenic shock, ARDS, or pneumonia? Keep in mind, sepsis has blood pressure issues, cardiogenic shock has blood pressure issues, ARDS has a lot of issues, and pneumonia, well, is pneumonia. All right, what does the dicrotic notch represent? Pulmonic valve, aortic valve, pulmonic semilunar, aortic semilunar, sorry, tricuspid valve, or mitral valve. If you need to pause and look these up and do it, right? What kind of change is seen with the respiratory cycle on arterial lines? Now, we're not assuming air trapping here. We're just in general. What kind of change is seen during respiratory cycle? Large decreases with inhalation, large increases with inhalation, large increase with exhalation, or minimal changes in general. Which of the following will cause blood pressure to decrease? Vasodilators, cardiac failure, hypovolemia. Next question, which is true about mean arterial pressure? Normal 70 to 105 millimeters of mercury. It's the average of systolic and diastolic pressure. Organ perfusion is compromised if less than 60 millimeters of mercury. Okay, so let's talk about central venous pressure. I like looking at this one. Mechanical ventilation, it's hard because when you're putting thoracic pressure, positive thoracic pressure in there, it can tend to artificially increase this value. Because remember, here we have, I'll just call it the thorax, right? And here's the lungs. So if we increase positive pressure ventilation, you have your vena cavas, superior and inferior vena cava that run through here. If I extend a lot of positive pressure on my lungs, I can squeeze that vena cava with mean airway pressure, with PEEP, and so on and so forth. So I'm going to artificially elevate it, because what's going to happen if I increase expansion on my lungs? It's going to squeeze the vena cava, right? So that pressure is going to increase, right? If we squeeze something, there's less volume and therefore more pressure, right? And so that's what's going to happen. Doesn't mean we can't use it on positive pressure ventilation patients, but what it does mean is, instead of looking at the numerical value and saying it's outside of normal limits, instead of looking at that, we're going to be looking at, where is it trending? Is our CVP trending higher? Is it trending lower? And we're going to go off of the trend, not the numerical value, usually with positive pressure ventilation. So I'm getting ahead of myself again, but hopefully that makes sense to you. So this is looking at blood in the right atria, or the vena cava, right? Ultimately, this evaluates the amount of blood in the right side of the heart, the amount of blood going to the right side of the heart, the amount of blood going to the right side of the heart. It evaluates the amount of blood going to the right side of the heart. Notice I repeated that one. That's important. It evaluates function of which ventricle then? The right ventricle, right? So represents end diastolic pressure in the right ventricle and right preload. So right ventricle, right preload, then diastolic pressure in there. And this is one thing that can tell us for non-intubated patients, or can tell us by trending, the fluid volume status. If we gave them too much diuretics, if we took off too much fluid during hemodialysis or CRRT or anything like that, it can look at that fluid volume status on trending. So a normal here, and you need to remember this, is 2 to 6 millimeters of mercury. 2 to 6 millimeters of mercury. Your board exams will ask you normals for the right atrial pressure, pulmonary, capillary wedge pressure, so on and so forth. So just be aware that you will need to know normals. In fact, a lot of the times those questions will be asking you in a roundabout way what a normal is. So as long as you got your normals down, that will be a big step for you. So indications to put in a CVP, if we are looking at their circulation blood volume, their volume status, that can be a big help there. Dehydration, hypertension, so on and so forth, especially if they've been in a trauma. It's a good way to look at their volume status. We can see the effectiveness of venous return, especially in things like sepsis, where you have massive vasodilation systemically, which is why their blood pressure will be super low, and that CVP can actually help us trend. So if their CVP starts to increase, it's not because their volume is low. Their CVP is increasing because we got better vascular tone, and therefore that means their sepsis is actually, hopefully, improving at that point. Evaluation of the right heart function, especially in those patients that have chronic pulmonary disease. Remember from disease class, most of your pulmonary diseases cause right ventricular issues because we have hypoxic pulmonary vasoconstriction. With hypoxic pulmonary vasoconstriction with respiratory issues, you're going to cause back pressure ultimately onto the right ventricle, which can make it damaged or ultimately cause that cor pulmonale, right? Especially with things like that chronic bronchitis type patients, all that stuff. So evaluation of the right ventricular function can be very important in some of these patients. So rapid infusions, it's great because we can give medications through there. Volume expanders, especially it's centrally located. It's going to dump into that vena cava and then dump right into the heart, where the heart can use it for the to distribute to the lungs. So that'll help the lungs get better VQ match, as well as ultimately to the left heart, which can help the heart have a better cardiac output, especially if they're hypovolemic. Beautiful use for it, centrally located. It can be used for labs. We can send a venous blood gas. If you're doing a shunt study and you don't have a swan in place, you can pull, and obviously it's not mixed, but you can pull simultaneous arterial and venous blood gases and then send that and use the VBG as sort of your mixed pulmonary gas. And it'll give you a rough area of where their shunt percentage is. And realistically, every time I did a shunt calculation, we did it off of the central line, because none of the patients I was asked to do a shunt equation on were swan patients. None of them had a swan in place where we could pull it from the pulmonary artery. So I had to do the best I can, which the closest place was the central line. So you'll just draw, you and another provider will draw simultaneous blood gases, one from the central line and one from the art line. And then you'll do those, use those values. The closest you can get to the heart, the best for VBG, right? So that's going to be the best place for that. CVC, you can get electrolytes from it. Major surgery, you can look at their blood volume, medication administration, rapid infusion of blood in trauma. They're going to be a lot more effective that way. Patient with severe dehydration issues, going to be a lot more rapid. Infusion, a lot better physiological response, a lot quicker physiological response. Pulmonary edema, we can look at the hydrostatic pressure and understand that the hydrostatic pressure is how high it is, or if they're responding. We can look at the right ventricle damage post-MI. That's going to be a big issue. You'll have patients that code 3 to 4 to even more times in a day, right? That one patient that codes time after time after time. And that's one thing we can look at is the right ventricular damage after that MI, and then we can adjust our strategies for caring for that patient with that in consideration. So it's going to give us some valuable information there. And especially if we're giving fluid replacement therapy, we can make sure that we don't overshoot it and then cause non-cardiogenic pulmonary edema. So it's pretty useful in a lot of different situations. So 7 French triple lumen is what you want to do, is usually what it is. Almost all the time, in fact, most hospitals, it's required to get a chest x-ray post-placement. The idea here is to make sure it's good in good location, just like an x-ray after you intubate someone. You want to make sure the ET tube's in the right location. Same thing here, you want to make sure it's in the right vessel. And then there's no pneumothorax as well with it. And you can cause a pneumothorax from both the subclavian route as well as the central line, the jugular route as well. So it's done for a couple of reasons. And that's why they may hold off on an x-ray post-intubation as long as we have good end tidal and all those other things. They might hold off if they're going to drop a central line because they're going to have to get an x-ray for that anyway. So you want to make sure it's in the right vessel. Some of the issues here that can happen, and I've seen this happen, just like that Allstate commercial. I know a thing or two because I've seen a thing or two, right? Not Allstate, that's State Farm. So they could puncture the subclavian artery. I had a emergency room physician that was putting in a central line on a suspected sepsis patient that was mechanically ventilated, and the line was pulsing with the patient's heart rate, and it was a very bright blood color, and ultimately it was determined that they had placed that into the artery, the subclavian artery, and not the subclavian vein. And so it was very interesting because holding pressure on the subclavian artery is not something easy to do because it's subclavian, it's behind the clavicle, right? It's hidden, right? So you know how art lines, when you pull them, you're supposed to hold pressure just like after an arterial stick, right? So that makes for a unique situation there. Chance for a pneumothorax. Pneumothorax in the subclavian area is more likely because you're going right behind the clavicle, which what's behind the clavicle? The apice of the lung, right? So a right-sided apical pneumothorax is possible if they go through the parietal pleura there. It's a lot more stable than the jugular location, especially for transporting to CT, IR, all those places. It's a lot more secure, a lot less likely to come out. It's a lot more difficult to place as far as putting it in than the jugular location, right? Not as easy to get to, and a lot of it's sort of blind. They can use ultrasound stuff like that, but not easy. The jugular location is a lot easier to place because there's no bone blocking it. It's a straight shot into the superior vena cava, so there's no curvature, and I think I have a picture in here of it. There's no curvature that has to happen. It's just going straight from the neck right to the superior vena cava. So a lot different when you have this arch versus this almost straight shot. A lot less risk for a pneumothorax. Doesn't mean it can't happen, no, because the line could actually perforate through the vena cava or through the vessel and then cause a pneumothorax as well. It's a lot less stable post-placement. You got to be very careful with their lines if they have a jugular line because moving it or anything like that, it's not going to be as deep of a location, and therefore it can take a lot less torsion and stress. So waveforms, I will ask you about waveforms. Expect test questions about waveforms on a CVP. Have we gone over this before? I don't think so, but we have, great. There are three waves. You have the A wave, the C wave, and the V wave. The A wave is not visible with atrial fibrillation because it represents atrial contraction. The A wave represents atrial contraction. So atrial contraction is what you're looking at there. When we're looking at a large A wave, that's where it's contracting against a closed tricuspid valve. Is that supposed to happen? Let me ask you that. Right? That's a question for you to look up and answer. I don't expect you to call me or email me or anything like that with it, but that's something that you should sort of look at. Which valves are open, which valves are closed during systole, diastole. Just saying. All right, the C wave represents ventricular contraction, so that's the right ventricle, of course. So an A wave is arterial contraction, C is ventricle contraction. And then I always remember the A wave is atrial and the C wave is ventricle because the right ventricle forms a C. Like if you're looking at the heart anatomy, I know I always draw the square heart thing, but it forms a C, so I always think of the right ventricle as the C wave, and then the A is the atrial because, you know, A and atrial go together. But I always see like that C shape with the heart. If you look at the heart anatomy, right, that's where it makes a C wave. So I know it's the right ventricular contraction. So if this is very weak, then I know it might be like a sign of cor pulmonale. If it somehow improves, if this wave improves with a positive inotrope, like dopamine, dopamine, something like that, then I see better ventricular contraction out of that right ventricle. Pretty cool, huh? The V wave is the last one, is filling with the valves closed. So the atria is being filled up with the valves being closed. So it's filling up with the valves being closed. If the V wave is big, that means there's tricuspid regurg. That means that the tricuspid valve that's in between the atria and the ventricle is open, and therefore we're seeing back pressure, because remember that right ventricle has more pressure than the right atrium, so that way we're seeing more pressure, back pressure, blood backing up into the atria, and that's what it's showing is that tricuspid regurg, right? Just like gastric reflux, there's stuff coming up the bad direction there, and that's what's causing that V wave to be exaggerated. So this is the waveform that you're typically looking at. This is straight from your Wilkins book, right? The A wave represents atrial contraction. The C wave represents ventricular contraction. And the V wave represents, you tell me. I love doing that stuff. All right, so when we're looking at this, if we have too big of a V wave, what does that mean? Okay, right, so this is the waveform. If we have if we don't have an A wave at all, and their EKG looks like this. No P wave, right? Just a bunch of randomness here. And then QRS complex. What are we looking at? Why is the A wave gone? Because the A wave represents atrial contraction, and we have no real P wave here. So that would be a fib, right? That's why it might be gone. C wave we hopefully should have as long as the right ventricle is working. V wave, you tell me what that's about. What does it mean if it's big? All right. So this is the picture from your book about a central line. So this is the jugular location. Like I was saying before, sort of that straight shot right into the superior vena cava compared to the subclavian where they have to literally aim behind the notch that. So on the subclavian, what they do is on yourself right now, feel for your notch, your on your clavicle. So you're going to feel where the clavicle sort of meets up with the sternum. You're going to sort of feel that knot or that end of that clavicle bone there. What they're going to do is they're going to aim a needle or catheter directly under that. And so it's a very hard stick. It'd be like doing an arterial stick underneath a bone, right? It's not easy. And obviously, if they go a little too deep, they can puncture and cause a pneumothorax as well. So that's what you're looking at here. It is usually a 7 French triple lumen, so we can do transducers and drugs and all the other good stuff there. So what about positive pressure? And I already talked about this in the first slide a little bit. It can change the CVP falsely. It'll show it higher than it actually is. So when we're looking at a high CVP with someone that's on positive pressure, whether it's non-invasive or invasive, that could be a sign that could make the numerical value higher than what it actually is. So let's say it's 2 to 6. Let's say we have a CVP of 4, okay, 4 millimeters of mercury, and the patient's on mechanical ventilation. Well, I know that number is falsely high because they're on positive pressure. So numerically, if I were to just look at the numbers alone, I'd be like, this patient has a normal CVP. But realistically, if it's supposed to be elevated with positive pressure, that patient actually might be hypovolemic. And I hope that sort of makes sense to you. So CVP traditionally is measured, that's why on CVP on positive pressure ventilation patients, we look at it on end exhalation, right? We look at it in exhalation. We don't have to extubate them or anything like that. We just, at end of exhalation, that's what we're trending. We trend the value. We don't look at the numerical value objectively, right? We trend that numerical value. Is it trending higher? Is it trending lower? So it's still valuable information. We're just not going to go off the normals. I don't know if that makes sense. So measured at end exhalation on a ventilator, it'll be falsely high. You just got to remember that at the end of exhalation, that's when we're going to sort of see that, and we're going to trend it to help tell us about the patient's situation. Complications can happen at placement when they're putting it in, right, the procedure itself, or over time. Bleeding, just like your arterial puncture, can easily happen. Low platelets, arterial puncture, like I said, the subclavian artery can be punctured. So that could all be a big issue. They could also cause a pneumothorax. Not very common because they usually use like an ultrasound to guide it, but it can still happen. The subclavian artery, please don't do this. Holding pressure on it is not easy. And in fact, especially if their platelets are low, don't pull it. Yeah, just get a consult. Infection, of course, just like putting it in or over time. That's why if a patient's starting to run a fever, we'll pull the line, central, arterial, so on and so forth. Send them for culture. And they can develop a thrombi here, just like an arterial line. The big thing here, don't leave that stopcock open. You can easily get an air embolus. It's not good because that'll go to the lungs, and that causes a pulmonary emboli. And then you'll see a sudden acute change in their saturations and increased right-sided heart pressures, and you'll be like, what's going on? Yeah, that's what happened. Interpretation, any factor that reduces blood returning to the heart can decrease CVP. So these are all things that can decrease CVP, okay? If I were to ask you in the future what would happen to CVP with hypovolemia, you would say that would decrease the CVP. If I said there were air bubbles or leaks in the line, you would say that would decrease CVP, right? So this is a list that could be very handy for you. So vasodilation, of course, especially pulmonary vasodilation, we might see a decreased trend. So let's say you put someone on nitric oxide on a ventilator or give them a flow line. You might see their CVP start to go down. That's a good sign, right? That means you're being therapeutic, right? Vasodilation, hypovolemia, they're losing fluids. Spontaneous inhalation, so you're going to see a lot more movement in this with spontaneous breathing than you did with your arterial line. So spontaneous inspiration, remember you're causing negative thoracic pressure, therefore your CVP will go down, right? Because you're pulling blood into the ventricle from the vena cava. Therefore, if we're pulling blood from the vena cava, which is where the central line is placed, then we're going to see a decrease in our CVP. Hopefully that made sense. Transducer placed above the right atrium. So there's a little transducer. I think there's a picture in here of it in the next slide or two. If the pressure, it should be in line with the atrium. If the pressure transducer is not, like let's say their head of bed is at 30 degrees and we lay the patient flat to take them to CT, take them on a transport to CAT scan or to IR or something like that, then it's going to read artificially low because it's lower than their heart, and so it's going to think that they're hypotensive or hypovolemic or they have vasodilation going on. When they don't, it's just not lined up with the transducer. So if you see something like that happen, one of your first thing might be like, hey, is it lined up with their heart before we start pushing fluids or doing anything like that, right? So if the transducer is high, that would cause their CVP to go down, or if there's air bubbles or leaks in the pressure line, that can easily do it as well. So these are a list of things that will cause it to increase. If we give the patient too much volume, if we have too much thoracic pressure, say high to high peeps, right? That can easily happen. Pulmonary hypertension. Now remember, pulmonary hypertension can happen a couple ways. Pulmonary hypertension, if we have a right to left shunt, a left to right shunt, like we have with that PFO patient, remember that PFO? Patent foramen ovale. If we have more pressure in the left than the right, so that pressure will go, we have that extra blood going into the right side of the heart, which means the pulmonary artery is going to have extra blood flow and therefore cause pulmonary hypertension, right? So that's that left to right shunt, like with a PFO or a PDA with a neonate, right? Or you can have pulmonary hypertension from pulmonary vasoconstriction, right? We go from a nice, juicy, thick vessel to a very thin vessel. And that's usually happens with hypoxia, right? Hypoxic pulmonary vasoconstriction. That means that the blood will back up, right, and cause an increased pressure on the right side of the heart. Therefore, the increased CVP, right? So pulmonary hypertension can happen from either extra blood volume or from vasoconstriction, right? So that's just something to look at. Left-sided heart failure, of course, we talked about that before. If the left ventricle is not pumping out blood, then it's going to back up into the left atrium. And it's going to back up the left atrium. It backs up through the pulmonary veins. And if it backs up through the pulmonary veins, it backs up into the pulmonary capillaries. If it backs up in the pulmonary capillaries, then it will back up into the pulmonary artery. If it backs up into the pulmonary artery, it'll back up to the right ventricle. If it backs up into the right ventricle, it'll back up into the right atrium. If it backs up into the right atrium, it will back up into the vena cava, which is where the CVP transducer is. Therefore, your CVP would be increased. Remember, this car accident started all the way in the left ventricle, and everything behind it was congested and clogged up. Bumper to bumper, red blood cells. I don't know if that makes sense. So left-sided heart failure, pulmonary valvular stenosis, that's that back pressure from not being able to go through there. Someone has a PE going on. Right, that's a great thing there. You'll see some of these PE patients, especially with the saddle emboli, their whole top half will turn purple from like their clavicles up, will be purple. right? Or this like mottled purple, grayish, weird tone look. And that can be a huge CVP on these patients. Someone has tricuspid stenosis or regurg. Hey, what CVP waveform would you see that tricuspid regurg? Would it be big, exaggerated, or would it be small? I love these questions. Vasoconstriction, we're giving them pressors, should increase. Placement of a transducer below the atrium. So let's say we lined up their transducer with the atrium and they were at 30 degrees and we take them up to 90 degrees for like an extubation or something like that. Then that obviously might cause an artificial increase in their CVP, not physiologically, but numerically, that's artificial, right? It's not what actually is going on. It's because we moved the transducer. So placement should be in the fourth intercostal, mid-axillary, even with the right atrium. So we want to make sure we line it up. So this is the proper placement. It can vary with the respiratory cycle. Remember, that was not common with the arterial line. So it is more common with the central line. If there's no variation with breathing, then there might be something wrong with the line. It could be like a kink. The stopcock could be turned in the wrong direction. A clot could be in there. One of the culprits that I usually see, so this is anecdotal, was the bed rail. Like the line is caught in the bed rail for some reason or another. The CVP, remember this one, and notice it's in all caps, is measured at end exhalation, and that's where we trend it. All right, so here are some basic questions for CVP. Reflects right ventricular filling volume, left ventricular filling volume, left atrial pressure, or pulmonary artery diastolic pressure. And you can always pause this and sort of look these up, make sure you got them down. And then every time you listen to this, while you're driving, while you're brushing your teeth, right, then you could be like, I know the answer to that, right? Which is least likely to need a CVP? Cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, pleural effusion, or a major trauma patient. Which is true about a CVP? It can be inserted into the subclavian vein. It can have multiple lumens. And it has a balloon on the distal tip. What does the C wave represent? Atrial contraction, ventricular contraction, atrial filling, ventricular filling. How are you to measure CVP on a ventilated patient? Do you guess? Do you measure it at end inhalation? Do you measure it at end exhalation? Or do you just extubate them, measure it, and then reintubate? All right, so we covered arterial lines, we covered CVP, and now this one's looking at pulmonary artery pressure. So this one's looking at pretty much using a Swan Gans catheter. So this would be, according to your board exams, a balloon tipped, right? Because there's a balloon on the end of this one. A balloon tipped flow directed catheter. So they can actually put the line in, inflate the balloon, and let the blood flow actually pull the catheter to the right place where it wedges, and then we can get a pulmonary capillary wedge pressure. Obviously, we're not going to leave the balloon up. We're going to measure it, but we're not going to leave the balloon up indefinitely for sure. That would be like an embolism. This one's great because we can actually measure cardiac output with it. Right, so it's usually like a temperature gradient or a flow gradient that we can look at cardiac output here. So it's a great measurement there. Like I said, most of your post-op hearts post-op open hearts. We'll have them here and there. There was a lot more risk of infection than benefits that we'd get from it because we have other ways of looking at some of this stuff with central lines and arterial lines and ultrasounds that really show that we don't have as much benefit from knowing these pressures as we used to, unless we have a certain case where we need to diagnose someone by looking at all these different pressures, or a certain procedure like a complicated open heart procedure where we have to watch every detail very closely, and we won't get as much detail with a CVP and arterial line and all that stuff. So Not as common, but you will see them out there. Pulmonary artery pressure. I do expect you to know these pressures. You're like, yay, thank you so much. Yay. I can hear the excitement of having to know these pressures. Looks at cardiac output, pulmonary artery pressures, systolic, diastolic, mean pulmonary artery pressure, wedge pressure, normal 6 to 12. So in ARDS, the 1994 definition of ARDS, I think that was the ACCP, American College of Chest Physicians. I'm not sure. I don't remember which agency came up with the old definition. The old definition for ARDS had to exclude a left-sided heart failure by looking at a pulmonary capillary wedge pressure of 18 or less. And so if you had a pulmonary capillary wedge pressure of 18, then that was a sign you had, or more. It had that meant that you were likely that the patient had left ventricular failure. Which doesn't mean you. So here, let me talk about this real quick. Is it possible that a patient can have ARDS where their lungs are just getting trashed on top of having left ventricular failure? Yes, right? They can have left ventricular failure and have a viral pneumonia that's causing severe ARDS. Those are completely things that could happen simultaneous. But when they were initially talking about diagnosing ARDS, you had to rule out cardiac failure. Even with the Berlin definition of ARDS, you have to rule out cardiogenic reasons. So just be aware there's a little bit of gray area there where someone can have simultaneous ARDS and left ventricular failure. However, it's sort of a gray area because by definition of ARDS, you have to rule out a cardiogenic reason. And the wedge pressure looks at left ventricle, right? So pulmonary artery pressures and pulmonary vascular resistance are all looking at right-sided heart pressures. And capillary wedge pressure looks at left-sided function, right? And we can get left ventricular stroke work index, we can get right ventricular stroke work index, we can get right atrial pressure, we can get cardiac output, we can get stroke volume, we can get so much more, systemic vascular resistance. All of those can be measured from the Swan catheter, right? So even more than what you're seeing here can be measured with it. So diagnostically, it's a huge advantage as far as the amount of detail it gives you, but the risks of infection usually outweigh the diagnostic value in most patients. Pulmonary capillary wedge pressure at the very bottom of the screen. PCWP is synonymous with pulmonary artery occlusion pressure. So if you see PAOP, it means the same thing. Remember how the respiratory zone has like 4 different names, like the functional unit, the respiratory zone, so on and so forth. Like there was 4 different terms for it. Same thing here. There's their synonymous. Pulmonary capillary wedge pressure and pulmonary artery occlusion pressure, PAOP, are synonymous. So don't freak out if you see PAOP. It means the same thing. So what are some indications for this line? It's case by case. The thing here, and we've already talked about it, is do the benefits outweigh the risks? If we have a severe cardiogenic pulmonary edema, then the benefits might outweigh the risk, because then we can sort of see in detail our therapeutic effect and how strong we need to be or how aggressive we need to be with it. Someone who's in severe ARDS, it might be an indication there to sort of see therapeutic effect and how much stress and pressure we're putting on the right and left ventricle, so on and so forth. Major thoracic surgery, usually, like I said, more your complex heart surgeries are going to use them traditionally. Location, they can either put it through the jugular or the subclavian, so they go through that central axis. The balloon tip flow-directed catheter, the balloon is inflated and the flow of blood directs it to the right side of the heart into the pulmonary artery pressure. The idea here is that after it's in that place, we deflate the balloon unless we're getting a pulmonary artery occlusion pressure. And I think it only uses like 1.3 mLs of air, so it's very, very small, and I think your book actually tells you the volume. But yeah, it's like very, very small volume of air because it's wedged. It's very far down, so you don't need a lot. And then that can tell you the function of that left ventricle there. All right, this screen, I like talking about this screen, especially if you're going to be in cath lab and doing vasoreactivity studies. This is something that you'll see as well in there. So diagnostically and therapeutically in the critical care unit, if they have to go and see one of these. Let me explain this to you and how I see it, right? So up here is telling you sort of where it's at in the heart. And then this is telling you the normal pressures of where they're at. And this bottom is the waveform. So let's talk about the waveform. So a central line is in the vena cava. You're going to see some changes with breathing, but overall it's going to be consistent pressure, right? You'll have some contraction and relaxation, so that's why you'll get atrial and ventricular contractions you'll see in there, and then filling. So you're not going to see a ton of peaks and valleys. You're going to see some, it looks like AFib a little bit, right? You're going to see just some movement, but that's about it. Then when you get into the right ventricle, that's when you start to have things like the tricuspid valve close, hopefully. And that's why during systole, you're actually going to see this ginormous spike, right? You're going to see an increase of pressure. Well, notice that the pressure when it decreases in diastole goes below where the central line is. Right, it goes below that because we emptied the ventricle, so our pressure in the ventricle during diastole is very low down here. So if you go from sort of that AFib flat line type thing to peak and valley that go below it, you know you're in the right ventricle, right? We've just squozen, which increased pressure, and then all the blood's gone, so that's why the pressure decreased. So hopefully you sort of see that physiologically what's going on. We made it to that ventricle, and we're just squeezing it out and emptying it, right? And then when we see it change to where our baseline is high, you see this over here that I'm underlining? That baseline is high. So we still see that peak, we still see that squeeze, but our baseline is much higher. That's because that pulmonary semilunar valve is closing and stopping blood from getting too low, right? So that's what you're seeing here, is that pulmonary semilunar valve is closed. So we still got the squeeze, we still got systole, we still got blood coming through, and then before that blood has a chance to empty, it doesn't, because we have that stop with the pulmonary semilunar valve stops it from closing. It's pretty cool. So if I see high peaks but no valleys, right? No significant valleys, then know we're in the pulmonary artery pressure. Then when we make it all the way back to that AFib look, but it's a much higher than our start, I know we're wedged. I hope this sort of makes sense to you a little bit there, because once we're wedged, we're just looking at back pressure from the left ventricle. So this is looking at left ventricle, right? How effective is how sick or how healthy is that left ventricle squeeze? Right? And so if this is very high, that means there's a lot of back pressure. That means the left ventricle is not squeezing out much. Right? If it's very low, then hopefully it's not very low. But if it's very low, then it could be hypovolemia, right? Something like that going on. So hopefully you have a little bit more appreciation for the waveform going through it. And so this is always a good thing just to sort of make sure you're familiar with. I like going through the physiology behind it because it makes a lot more sense. I can look at it and sort of know exactly where they're at and then what's going on with their pressures and their pulmonary artery pressure, especially if you're in a vasoreactivity study. It can be very helpful. So some complications with the Swan-Ganz or the balloon tip fluid directed catheter. Pneumothorax, of course, right? Just because we're putting it in that central location, especially if we're putting it subclavian. Hydrothorax or hemothorax, air embolisms can happen if the line's left open or that balloon bursts. Damage, of course, and nerves, including nerves, can happen. And of course, this was the big one, and that's why we have to look at risk-versus benefits, is infection, right? There was a very significant infection associated with them, so that's why they're not usually leaving them in for prolonged periods of time. Interpretation, decreased venous return, low thoracic pressure, low pulmonary vascular resistance would all cause these to be low. So if we gave a patient a lot of pulmonary vasodilators or they were hypovolemic, anything like that would cause these pressures to be low. These pressures are going to be high if we have a lot of venous return, so we give this patient lots of fluids, high thoracic pressure, right? That's that artificially elevation, or high pulmonary vascular resistance. One of your key things that can happen here is hypoxic pulmonary vasoconstriction. So you'll know if your patient's hypoxic, right? Their sats are low, they're on high FiO2s, their PO2s are low, right? That's why their PVR is high. That's why their CVP is high, right? That's why their right atrial pressure is high. So high PVR can also be indicative of a pulmonary emboli, of course, lung disease. That's what I talk about now. Cardiac tamponade can cause this as well, because remember the left ventricle is being restricted in its motion because blood's filling up in that pericardial sac, and so that's what's going to cause that back pressure there, or because the left ventricle isn't squeezing much out, and so everything's just backing up behind it. Most common cause for a high wedge pressure is left ventricular failure. Seems like this would be important for you to know. Hint, wink, exclamation point. All right, most common cause for low wedge pressure is hypovolemia. Seems like this would be important to know. Hint and wink applied.